Hi, today we are talking about COVID-19, and I'd like to do a bit of a reset. Lately, we have been so focused on vaccine and the rollout and distribution, and also on politics. We haven't really talked lately about what's going on the front lines. The US has exceeded 25 million COVID-19 cases. And while it seems that we're coming down from a recent peak, there are concerns about new variants that may be more contagious and could drive the numbers back up. I live in LA, where we have had the worst COVID outbreak since the one we saw in New York City, so substantial that they waived air quality regulations to allow for more. I'm dropping out, so I said to allow more cremations in the city. To discuss this, I have a very special guest, and I'm about to bring him in. His name is Dr. Thomas Yadagar. He is medical director of the ICU at one of the best hospitals in Los Angeles. He and his team have treated thousands of COVID patients. His specialty is pulmonary medicine. He is a practiced pulmonary and critical care a doctor, and he's practiced it for the last 25 years. Dr. Yadagar, I'm about to bring you in right now for being here and for sharing your time with us. Hi.
Hi, Jessica.
Thank you for being here today.
Of course. Thank you for having me.
I thought I'd start by asking, before we get into specifics, broadly speaking, for folks who don't really know what's going on the front lines, what's the scene at your ICU?
Well, the past 2 months has been brutal, to be honest with you. In early December, we had very manageable census. We were a normal functioning hospital. And it seemed like within a 2-week span, our COVID census numbers just kept doubling every 5 to 10 days. And in a short time, we went from, a very manageable census to having 80% of our hospital be filled with COVID patients. We had to expand our ICU 250%, and even with that, 90% of our ICU was at capacity with COVID-19 patients.
I've seen some of the videos you posted on Instagram of nurses, and it sounds to me like you might be a little exhausted yourself. How is everybody dealing with the mental aspect of this as healthcare providers? How are you?
To be honest with you, I don't think it's really hit us. I think all of us, nurses, doctors, respiratory therapists, we get up in the morning and we know what we need to do. So we try to put aside what happens on a daily basis, and I'm sure that it's deep in our conscious and it just hasn't really hit us. And we're just trying to get through a day at a time and hope that, we turn the page in this pandemic once everyone gets vaccinated.
Mm-hmm. And I think I spoke to you the other day, and it was your first day off in like a month.
Yes, my phone never stops ringing, and but this is what I signed up for, and this is what I'm supposed to do.
Okay. So in California, they've started to open back up. They're saying it's safe to open. Are the numbers really getting better, and do you think it's safe to open?
There is some positive numbers. One of the things that we look at is the 7-day and the 14-day test positivity rates, and those have both decreased in California as well as in Los Angeles. And if you look at hospitalizations, those have also decreased both within Los Angeles as well as in California. ICU utilization and unfortunately deaths are a lagging indicator. So hopefully in the next week or two, those numbers will will improve. But, we're still losing an Angelino every 5 minutes, which is, just absurd that we are losing so many lives.
When you talk a little bit about what you see in the ICU, is there any common denominator among the people who get hardest hit by COVID? Are you starting to see younger people rather than older people come in to ICU?
No, one of the things that happens with this disease is that there isn't anything that's uniform about it. I think the unpredictability is what makes it such a challenging and difficult disease to treat. And everyone that comes into the hospital, everyone that comes into the ICU is almost having a different disease process. And that's what makes it so difficult, in that you can't go through the ICU and treat everyone with the same magic, potion. You have to go into every ICU room and figure out what's happening to that patient and give them a very individualized therapy.
What is one thing about COVID-19 we don't talk enough about that you'd like people to know about?
Well, I think the one thing that I've really been talking and focusing on is the cytokine storm. That's something that we noticed was happening to these patients in March. And unfortunately, it's not a small minority of patients. You know, in our hospital, as you said, we have treated over 1,000 patients. And for the cytokine storm, that's over about 200 patients that we've treated specifically for that disorder.
So explain to some of us do know what it is, but for those who aren't so familiar, can you give a summary of what the cytokine storm is?
Sure. I think the key thing is, how does COVID-19 kill patients? I mean, that's one of the key things that everyone needs to understand. So for the patients that are elderly, for the patients that are frail, for the patients that have chronic heart, lung, kidney disease, and cancer, the way that COVID-19 kills those patients is that it's obviously a viral infection, and it eventually just overwhelms their body, and they go into multi-system failure and they succumb. From this aspect, COVID-19 is not any different than any other pathogen. We lose 30 to 50,000 people to influenza every fall and winter due to the same process. The one thing that COVID-19 does that it's extremely difficult and different than every other pathogen is that it induces this cytokine storm. So if I can explain that to you.
Please, yeah.
A patient gets the viral infection, and for the most part, our immune system, which is incredibly complicated, figures out that we are under attack by a virus. Our immune system will activate certain cells, it communicates with each other, and then it will eventually kill the virus as well as the cells that are infected with the virus. For 80%, 85% of the people that get this virus, this is what happens, and it works well. But there's a small set of patients where the infection kind of tricks the immune system. And instead of your immune system working in concert and fighting the virus, the immune system essentially turns on the patient's body and starts attacking the lungs, the blood vessels, the kidneys. And you go into a multi-system organ failure, not from the virus, but essentially from your own body.
Okay, that sounds terrible. And it's very hard to treat. Can you explain why that's so hard to treat?
Well, first thing is it's a very elusive disorder. I've been doing critical care for 20 years, and this is the cytokine storm aspect happens very, very infrequently. I've only seen 1 or 2 cases in my 20 years of treating critical care patients.
Prior to COVID.
Prior to COVID. It wasn't something that happened. So a lot of critical care doctors aren't even really aware of it. The other part that makes it difficult is that there isn't any one pathognomonic laboratory test or X-ray. There isn't something that you can order that you can says, okay, this patient is having a cytokine storm. The clinician really needs to do a thorough history and physical, and then at the end of it, they need to depend on their clinical judgment because it's a disorder, what we call disorder of exclusion. That means that you've excluded people who have blood clots and people who have heart failure or secondary infections. And when you realize that this patient's in respiratory failure and there isn't any other causes, and they have elevated inflammatory markers, and they're in their 2nd week of their illness, that's when you know that they're in a cytokine storm.
So that's something you'd said to me before. Can you explain, if I'm a COVID patient at home, how do I know when I might be having the cytokine storm or when I need to get to the hospital?
So that's an excellent question. That's critical. I think the first thing is, for the first 3 to 5 days of this infection, it's a viral infection. So either you have a bad head cold or you may have a bad flu. And for the most people, again, they recover within those 3 to 5 days. It's really in the 2nd week of the illness. So if you're still having symptoms after the 5, 6, and especially day 7, then that's when you may be having the cytokine storm, because it usually happens in the 2nd week of the symptom onset. It doesn't happen within the first few days. And the symptoms, unfortunately, are very similar to the actual viral infection. So patients will have increasing cough, they'll have fever, and they'll have shortness of breath. And these are the patients that we hear where their oxygen levels suddenly drop. And unfortunately, when they go to the urgent care, when they go to the emergency room, if the doctors aren't aware that this is happening, they'll treat them with antibiotics or they'll treat them with other, medications that won't work, and they'll send them home. And that's when you hear of all these horrible cases where someone went to the emergency room, went home, and then was found dead 2 days later. That's the cytokine storm.
It's your own immune system attacking you in a way, yeah? It's an autoimmune. So how do you treat it?
So that's the unfortunate part, is that the treatment is almost a leap of faith. Again, you have to trust your clinical judgment, and the treatment is very counterintuitive because this patient who came into your hospital, who came into your ICU with this deadly viral infection, what you have to do is you have to give them strong immunosuppressive medication. That's the way you treat it, is by suppressing the immune system, which again, for a critical care physician, if you came into my ICU a year ago, Jessica, and you told me that you want to give my ICU patients immunosuppressive agents, I would have called security and had you escorted out. That's not something that we do as critical care physicians. We always want to boost the patient's immune system because the patient usually succumbs to an infection in the ICU. To suppress their immune system, that's a very difficult decision to make.
Wow. We have a lot of nurses in this audience and some doctors, and they asked specifically, let me see. Okay, I don't know if you can answer this, and if this is not appropriate to answer, don't. Do you recommend treating the cytokine storm with an IL-1 and or IL-6, and do you place those before dexamethasone? A lot of people ask that.
Yeah, so that's an excellent question, and I think for the nurses and the doctors, if you go to UpToDate, there's already a protocol of how to treat cytokine release syndrome, cytokine storm. So the first thing that we do is we base it on the patient's oxygen-based status. So if their oxygen requirements are below what we call 40%, that means they're on simple oxygen, then we just increase the dexamethasone. And in a significant amount of patients, just increasing the dexamethasone, increasing the steroid, because steroids are anti-inflammatories, that will make it go away. As well as we initiate prone ventilation very early on. That's when the patient lies on their stomach for 16 to 18 hours a day. But if they progress, if they start needing more and more oxygen, that's when we initiate therapy with IL-6 inhibitors.
I see. Okay. Is there a point at which you have to intervene with a cytokine storm, and if you don't catch it early enough, it's too late?
Yes. So I think the way I explain this to people and the way to really understand it is, imagine, we live in LA, so imagine you're standing on a beach and you're having waves that are coming at you, because that's what cytokine storm is. It's a disease that comes at you in waves. And the initial waves are very small, maybe 2 or 3 feet, and if you treat it, it'll go away. But if you don't treat it, the waves will build up. And the next set of waves that come in may be 10 feet. And the next set of waves after that may be a 200-foot tsunami. So the way that we treat it is we treat it super early and super aggressive. And it's as soon as the patient transitions from needing what we call low flow oxygen to high flow oxygen. So once they start needing more than 7 or 10 liters of oxygen, that's when it becomes a medical emergency for us. And one of the things that it's been so difficult to explain to the nurses and the respiratory therapists, because nurses and respiratory therapists, when they treat pneumonia patients, if they take them from needing 2 liters to 5 liters, that's usually not even something they think about. But I've had to retrain them to know that, no, in this patient population, if your oxygen has gone from 2 liters to 5 liters, that's a medical emergency. We need to be notified because we need to evaluate the patient, because it takes a couple of hours to get the medications into the patient.
Are there any known conditions that predispose a patient to the cytokine storm?
Yes, what I have found is that diabetes as well as obesity, those are the 2 main indicators that we see lead to cytokine storm. And the patients that we're seeing it in are patients that are in their 40s, in their 50s, in their 60s. These are not the older patient population. The ones that get the fulminant storm, those are the younger patient population. Those are their essential care workers. Those are the ones that are grocery clerks. Those are the ones that are teachers that are acquiring it. So I think it's really essential for doctors to recognize it and to treat it.
Do you think it's dose dependent? Like how much of the viral load you get determines this, or no?
I think that's definitely plays a role. And I think there's also a genetic predisposition to it. There's nothing about this virus or this disease that's an easy answer. So I think it's probably multifactorial, and it probably has a lot of different factors that play a role in its involvement.
Does smoking play a role? Like, does that predispose people to trip the storm?
Not that I have seen, but I mean, obviously smoking predisposes you to COPD, and COPD is one of the chronic lung conditions that predispose you to having severe COVID-19.
Do the COVID antibody cocktails we've heard about help avoid this, and how available are they?
The answer to your second question is definitely not as available as they should be at this point. Yes, I think, again, what we have noticed is if you can initiate therapy as soon as possible, and by initiating therapy with the COVID antibodies, the monoclonal antibodies, by decreasing the viral load, by treating this disease as early as possible, then hopefully you can minimize hospitalization, minimize emergency room visits, and prevent the cytokine storm from happening.
And you're saying they should be more available, this cocktail. It's just not produced at a high enough rate right now, or it's too expensive to get?
I think the most difficult part is actually receiving it. I think there is a fair amount that's sitting there on shelves and not being utilized. Part of it is that it's the EUA that it received was for it to be used in a hospitalized setting, and a lot of hospitals are having difficulties in terms of getting the protocol because now you have to bring a patient who's COVID-19 into your hospital, figure out where you could have them receive this infusion for a couple of hours. So that
Oh,
makes it
because you
difficult.
get it early in the disease. It's not when they're already in the ICU.
No, it's not for hospitalized patients. It's for
I see,
outpatients.
right.
Yeah, it's for patients that are at home, and it's for patients who do not require oxygen. It's not
So
approved.
it's early stage and they're not, yeah. But it's
Yeah,
a drip, so they need to be on an IV? I see.
yeah, yes. It's a 1 hour infusion, and then they have to be monitored for another hour just to make sure they're not having any side effects.
So they need to change that EUA.
They need to change the EUA. I know that some of the CVS, some of the drugstores are actually doing home health, and they're sending a nurse, and there's
Wow.
patients who are receiving it at home. But again, it's not enough. It needs to be more widespread because you know again, the earlier you can treat the patient, then hopefully the less they'll need hospitalization and the less bad outcomes we'll have.
Are there other therapeutics we should be talking about and aware of? We focus so much on the vaccine, but there's therapies to treat some of this.
There are, we use remdesivir, which is antiviral. Again, that really needs to be used early in the disease course. A lot of patients wait till they're, 5, 6, 7 days into their disease course, and I'm not sure how well that medication helps. And then we do use dexamethasone, which is a steroid for anyone that's hospitalized that requires oxygen. But as I stated, if we notice that they're having a cytokine storm, we'll actually increase the dose as well as the frequency.
Got it. So a couple questions from the audience. People are asking, do you often see severe COVID cases among people who've been pretty cautious with masks and social distancing?
Yes, unfortunately, once you get the virus, once you're infected with the virus, there really isn't, at that point, there really isn't any rhyme or reason to why someone develops it. But it is people typically in their 40s to 60s, and it's, people who have diabetes or obesity that develop it. And it's, again, in their second week of their symptom onset.
And do you find any correlation, like people who show up with bad in the ICU, do they tend to be not mask wearers? Or you don't
No,
actually know?
no, I haven't found it there.
Okay. How do you protect yourself if you have to care for a family member with COVID?
Well, I think the first thing is that you need to isolate them and try to have them in a separate bedroom and a separate bathroom if possible. That would be the best case scenario. And then try to minimize your contact with them. And if you have to give them food, if you have to give them, shopping, you do their shopping, all that stuff. But you leave it by the door, and you have them be away from you when they are going to get it. So the main thing is to distance yourself as much as possible.
Is it really helpful for people with antibodies to donate blood?
It is. We do use convalescent serum for our patient population, and it does seem to work, although it's not, it doesn't work on every single patient, and that's what the studies have shown, is that it isn't beneficial for everyone. But there is, I've had some of our doctors, some of our hospitalists who developed COVID-19 and received this, the convalescent serum, and they swear that as they were getting the transfusion, that's when their disease really turned around. That's when their symptoms got better. That's when their fevers went away.
Wow. So it makes a difference for some people. Well, I know the answer to this, but people are asking, is there an effective nip it in the bud treatment available that consistently works if caught early? Or does everyone respond differently? You're saying everyone responds differently.
Yeah, unfortunately, we haven't found one. But, I think everyone in the world is looking for that nip it in the bud, drug or medication that would prevent this disease from progressing.
As somebody who works in the hospital, what is the best way for families to stay well informed if a loved one is in the hospital right now?
Yeah, I think that's been the hardest part of it, is that we are not allowing family members at bedside. For 20 years, I've been telling family members they're at bedside when their loved ones are on a ventilator and they're in a drug-induced coma to keep them on a ventilator and keep them comfortable. I tell them that please hold your loved one's hand. Please tell them, gently that you're here, that you love them, because there isn't any medication that I can give that can replace that love and the hope that the patient can get from the family members. So that's been the hardest part of this whole process, because again, that's something that we are doing ourselves. So fortunately, I think in the past couple of weeks we have laxed some of those rules, and we are trying to allow more family members. But I think again, just talking to the nurses, letting us know, how to best get a hold of you, and leaving one family representative to be in charge of communication, that really helps us to be able to get the information out to the family.
Are you seeing signs that these additional strains are making things worse or are more causing more severe illness?
Yeah, I think that's been the million-dollar question the past month and a half. What we have seen is that there's definitely a lot more patients that are in their severe COVID-19 and need ICU care. It was hard to determine whether that's just because they're presenting at a later stage, because again, we were so overwhelmed, and I had a lot of patients that told me that, they didn't want to come any earlier because they thought there was no room for them in the hospital, or they thought that there's someone even sicker that may need that hospital bed. So it was hard to determine whether that's the main reason why we saw so many more severe cases and so much more death. But I think the one thing that changes it for me is that in the past month, I've had 6 different families where I've treated husband and wives together, and I
In the
even have,
ICU.
yes, in the hospital, in the ICU, and I even have one where I have a husband and wife as well as their son. Now, 8 months ago, we were seeing multiple family members get infected, multiple family members become sick, but usually only one needed hospitalization. In the first 9 months of this disease, I don't remember a case where I had a husband and wife together in the hospital at the same time. But in the past month, I've had 6 just in our hospital. So to me, it tells me that maybe there's definitely a little bit more virulence to the strain, and the mutated viruses are not only more contagious, but they are definitely making people sicker.
How are you guys keeping yourselves safe?
Well, I mean, fortunately, I've been vaccinated.
Good.
I received my first and second shots. But
Great.
I've been taking care of people with respiratory viruses for 20 years. So you learn, you learn to stay away, you learn to keep a distance, you learn to wash your hands. Wearing a mask for me was not an issue. And not only do I wear a mask, but I also wear a shield. So it's not difficult. It's not hard to protect yourself if you know what you're doing, but you also have to commit to it. It's not washing your hands just in the morning and then, before you eat. It's washing your hands anytime you touch a foreign object. If you touch a door handle, if you're touching, the computers, to wash your hands, before every meal. So it's a lot of that, but again, after 20 years, I've learned to do a lot.
Do you get pissed off when you leave work and you're driving home and you see people walking around without masks or hanging out without social distancing?
It's frustrating. I'm not going to lie to you. It is frustrating because, we want everyone to protect themselves. We don't want to see anyone in the hospital. This disease, patients are struggling for every breath for days and days, for weeks and weeks. I wouldn't wish this disease on anyone. But I understand also that I don't think we've done a good enough job of really letting the public know what's happening inside the 4 walls of the hospital. And that's what I've really tried to, get out in the media and tell people the real story to understand how to protect themselves and how to keep safe.
So if we want to leave the audience with parting thoughts, what is it that you really want them to keep in mind and focus on to get the message out about COVID right now?
Well, I think the most important thing is to be an advocate for yourself. And if you are still having symptoms after day 5, please make sure you get to see a physician. Please be evaluated for cytokine storm, which usually happens again in the 2nd week of the illness. The earlier that you can get admitted to the hospital, the earlier that we can initiate therapy, the more chances that we have of having a positive outcome. And please don't delay getting medical care, whether it's for COVID or for chest pain or stroke symptoms. Don't try to be a doctor. You're a patient. Bring yourself to the hospital. It's our job to find a bed for you, and we will have doctors and nurses that will take care of you.
I just want to say, I get migraines, and a doctor once said to me, I was like, when do I take the medicine? He says, the minute you think, do I have a migraine? Should I take the medicine? That's when you take the medicine. So it sounds to me what you're telling people is the minute the question arises, should I go to the hospital, before you say no or talk yourself out of it, go? Is that what you're saying?
I'm telling you, the minute that you feel sick, get in contact with your primary care doctor, with your doctor. Right now, a lot of doctors are also doing telemedicine, so it shouldn't be difficult to get in front of someone who has been treating COVID-19 patients. And if you're not getting better, especially after day 5, if you're still having symptoms and you're getting worse, don't sit at home and think that it's going to get better. If you're not getting better, come to the hospital, come to the emergency room, let us evaluate you, and let's make sure that if you are having this syndrome, that we treat you as early as possible so that we can get you home as soon as possible.
Dr. Yadigar, thank you so much for your time and for your work and what you're doing for this community. I can't imagine how hard this is on you and your team. And I live here. I'm so grateful to you. Thank you.
Thank you, Jessica. Thank you.
Thanks. What an amazing man. Thank you for your time. To everybody watching this, I'm going to post it to gallery so you can repost and share. I can only imagine what he's seen lately. The descriptions out of the emergency rooms here are horrific. Grateful for his time and for sticking with me, and I'll see you all soon.